My name's Arj, and I'm in my third year after graduation from the University of Western Australia. I'm currently working as the Medical Service Improvement RMO at one of the Innovation Improvement Units at a tertiary hospital. I hope to share with you today my experience with medical service improvement, as well as how my understanding of leadership in healthcare has evolved. Now, if you're anything like I was in medical school, you're probably seated towards the back and already starting to zone out, so I'll try to keep this short. As an intern, my goal was not to change the system, or even to understand the system. My goal was to ensure that I made it one more day without killing someone. My goal was to make sure that I charted the right medications. My goal was to make sure that I cannulated the right patient. And since I was focusing on all these everyday tasks, I didn't actually bother to put a label on it. But essentially, my goal was still patient safety. And every doctor that graduates hopes to ensure that their patients are safe. No doctor wakes up in the morning and plans to compromise patient safety. Yet, patient safety is frequently compromised due to the inefficiencies in the system. Now, as time went on, the problems with the system started becoming more and more glaring. I applied for the MSI program in order to stop being part of the problem and start being part of the solution. On the first day of my MSI program, I walked in filled with optimism on all sorts of ideas on how I would improve the system. However, I was informed that I will be tackling the age-old problem of clinical incident reporting by medical staff. Now, if you don't know what clinical incident reporting is, don't worry. Apparently neither do most doctors. That's the point. Now, around the world, they have a system of reporting incidents when things go wrong, when there's a near miss, or so the organization can fix the holes in the system so it doesn't happen again. Now, incident reporting is meant to be one of the commonest mechanisms to learn from harm events and near misses. But the literature says that only a small percentage of incidents are actually reported at all, and that doctors are the worst at reporting. I remember thinking, what does the literature know about what we do in Perth, of all places? I wanted to prove it was a problem here before I did any work. So that's what I did. I found that in 2015, of all the incidents that were put in at my hospital, 2% were by medical staff. 2%, that's it. That's the amount of fat in skim milk. Next up, I surveyed 92 doctors to find out their level of awareness. Less than 50% were aware of what an incident was, and only 27% knew how to report an incident. 95% of doctors had never even seen the policy, and 93% had never reported an incident. I remember getting to this stage and thinking, how can I fix a problem of this magnitude in only 10 weeks? I'm not a wizard anymore. Thankfully though, my survey had one last question. Clinical incident reporting is worthwhile in learning from and implementing quality improvement activities to reduce their occurrence. There was a 90% response rate to either agree or strongly agree with this statement. This was my burning platform. This suggested that although there was a deep lack of awareness on what an incident was, a deep lack of awareness on the reporting process, and no awareness at all on the policy, doctors overwhelmingly agreed that incident reporting was important. It was at this moment I realized there was a huge opportunity to rectify this gulf between awareness and action. Like in clinical medicine, I needed to diagnose the problem before I could treat it. So according to doctors, what was the problem? Well, we had 5 main causes, including a lack of awareness about how to report an incident, the negative connotations associated with reporting, the lack of awareness about responsibility, the lack of knowledge on what to report, and feedback once a report had been made. In terms of solutions, I wanted to make the application for incident reporting easily available on all computers, so that's what I did. I also put up posters explaining how to report. I set up a helpline for doctors to call through if they weren't sure what to report, and I ensured an email feedback system occurred as well. And finally, I decided I'll make a quick video highlighting the importance of clinical incident reporting. So if you end up at my hospital, you'll know who to thank for having to sit through another educational video. What were those lessons I said? I found that trying to change the system in healthcare is difficult because you might be able to improve the procedures and protocols, but you might lose the whole purpose of healthcare. It's not like running a business. It's not like building a helicopter or playing The Sims. It's about human beings. It's the balance between efficiency and patient safety. This program taught me that leadership is not about any specific attributes or behavior. Leadership occurs every day, yet we don't see it. We have built up leadership as something bigger than us, something that we may or may not achieve at some point in the future, something that's huge. We've made it about changing the hospital, or changing healthcare, or changing the world. Yes, that is important, but that's not the goal of this program. The MSI program teaches us the required skills to understand the process, the required skills to realize that leadership is not something beyond our reach, and the required skills to appreciate leaders on their own actually can't do anything, but they can create a culture and a climate in which change is not feared. In healthcare, we have to learn to do more with less, which means we have to learn to innovate, and innovation demands leadership.